Hello and welcome, Doctors in Training. In today's OSCE Prep session, we are covering a high-yield and often emotionally charged topic, eating disorders. This session will guide you through the diagnostic criteria, screening tools, relevant investigations and management, both pharmacological and non-pharmacological, as well as when to refer or admit the patient. Let's begin. Eating disorders are serious psychiatric conditions characterized by persistent disturbances in eating behavior that significantly impair physical health and psychosocial functioning. The main types you need to know for OSCEs are number 1, anorexia nervosa, number 2, bulimia nervosa, number 3, binge eating disorder, and number 4, other specified feeding or eating disorders or OSFED. Now let's walk through the diagnostic criteria starting with anorexia. According to the DSM-5, here are the criteria. For anorexia nervosa, number 1, restriction of energy intake leading to significantly low body weight. Number 2, intense fear of gaining weight or becoming fat or persistent behavior that interferes with weight gain. Number 3, disturbances in self-perceived weight or shape. There are two subtypes for anorexia nervosa. Number 1 is the restricting type, number 2 is binge eating or purging type. For bulimia nervosa, the criteria are number 1, recurrent episodes of binge eating, number 2, recurrent inappropriate compensatory behavior such as vomiting, laxative use, or excessive exercise. Number 3, the binge purge cycle occurs at least once a week for 3 months. Number 4, self-evaluation is unduly influenced by body shape and weight. Number 5, the disturbance does not occur exclusively during the episodes of anorexia. For binge eating disorder, the criteria are recurrent binge eating without compensatory behavior. Episodes include at least 3 of the following: either eating rapidly, eating until uncomfortably full, eating when not hungry, eating alone due to embarrassment, or feeling disgusted afterwards. These must occur at least once per week for 3 months as well. When time is limited in the OSCE or clinic, use validated screening tools. One of the examples are SCOFF questionnaires, which contains 5 simple yes or no questions. For S, you can ask the patient, do you make yourself sick because you feel uncomfortably full? C, for you can ask the patient, do you worry you have lost control over how much you eat? O, you can ask the patient, have you recently lost more than 1 stone, about 6 kilograms in 3 months? F, you can ask the patients, do you believe yourself to be fat when others say you are too thin? And another F is, would you say that food dominates your life? 2 or more positive responses point towards likely eating disorder and warrants further evaluation. Other tools that you can use in the clinic include the EDEQ, which are the Eating Disorder Examination Questionnaires, and ESP, which is the Eating Disorder Screen for Primary Care. Investigations are important to assess medical complications of eating disorders. You can send bloods for full blood count to look for anemia or leukopenia, electrolytes, especially potassium for vomiting or laxative use, LFTs that may result in starvation, TFTs to rule out endocrine causes, blood glucose for hypoglycemia, phosphate to look for risk of refeeding syndrome, and ESR and CRP, which usually is normal in anorexia but is helpful in ruling out inflammatory disease. You can do ECG to look for signs of severe eating disorders such as bradycardia, QTc prolongation, as well as arrhythmias. Because patients with anorexia or certain eating disorders, they can have chronically low BMI, so you need to screen for osteoporosis, so you can do a DEXA scan for this. For the management for eating disorders are basically biopsychosocial, as well as and ideally involves a multidisciplinary team containing you yourself as a GP, psychologist, dietitian, and a psychiatrist. So let's break into non-pharmacological and pharmacological strategies. For non-pharmacological management, you can do psychoeducation for the patient and the family, nutritional rehabilitation, which involves gradual increase in calories intake, avoiding refeeding syndrome, and then you can refer the patient for CBTE, which is an enhanced cognitive behavioral therapy, which is actually the first line psychological therapy for eating disorders. And then you can also employ family-based therapy, especially for adolescents using the Maudsley model. And then you need to monitor the patient for regular weight, vitals, and labs. In primary care, your role includes early identification, medical monitoring, and coordinating referrals. So, with regards to pharmacological management, medication is not first line, but may be considered for comorbid conditions or as an adjunct therapy. So, you can use fluoxetine, which is a type of SSRI, which is approved for bulimia nervosa, also helpful in binge eating disorder. And then you can also use lisdexamfetamine, may be used for binge eating disorders in adults, and then you can use atypical antipsychotics such as olanzapine, sometimes used for off-label in anorexia nervosa for weight gain and anxiety effects. But be cautioned because SSRIs are ineffective in underweight anorexic patients due to low serotonin levels in these patients. What are the indications for hospital admission? You need to know your red flags for urgent admission. These are commonly tested in the OSCEs. The red flags are, number 1, BMI of less than 13 or rapid weight loss. Number 2, severe electrolyte imbalance such as hypokalemia, where the potassium is less than 2.5, and then bradycardia of less than 40 beats per minute, or if there's any evidence of postural hypotension, and then ECG abnormalities which may show QTc prolongation of more than 500 milliseconds, and then hypothermia if the temperature is less than 35 degrees Celsius, and if patient refused to eat or drink at all, and then if this patient has any suicidal ideation or very severe psychiatric comorbidities, and then if there's failure in your outpatient management, or if the patient deteriorates despite support that you provided them. In Malaysia, considering referring to psychiatric services with inpatient facilities or an eating disorder unit is strongly advised. To summarize, use DSM-5 for diagnosis. You can use simple SCOFF questionnaires for quick screening for patients suspected of eating disorders, and then you can investigate for complications early in the primary care. Focus on multidisciplinary and holistic management approach for each patient, and know when to escalate or admit the patient. Eating disorders requires both clinical vigilance and empathetic communication. Always approach with sensitivity and respect. Thanks for watching this OSCE prep session on eating disorder. Stay tuned for more videos covering high-yield topics in family medicine. Until then, stay sharp, stay compassionate, and all the best in your training.